Welcome to the EIU podcast. In this episode, UROONCO Kidney Cancer Chief Editor Dr. Carmen Mir talks to Professor Laurence Albiges on her abstract she presented at the ASCO2024.
So welcome back to our podcast for the UROONCO platform, in this case, kidney cancer. My name is Carmen Mir, and I'm the chief editor for the kidney cancer part of the platform. Today, we welcome Laurence Albiges. She's a well-known worldwide expert GU medical oncologist. She works at Gustave Roussy in Paris, France. She's going to talk to us today about her presentation at ASCO2024 in Chicago. Welcome, Laurence.
Thank you, Carmen. My pleasure to be with you.
So, I had the chance to present at this ASCO a piece that is a biomarker piece, actually, that was embedded in an adjuvant trials. So we are all familiar with the fact that all checkpoint inhibitors did not read out to be positive in the adjuvant space, and pembro is the agent that is currently approved. But some trials did not demonstrate benefit. And one of them is IMmotion010 study, which in the past had enrolled patients with resected intermediate to high-risk RCC to randomize atezolizumab or placebo for 1 year. And the trial has been previously presented and published, did not demonstrate an investigator-assessed disease-free survival benefit for atezolizumab over placebo. And the hazard ratio was 0.93. So what is important now is that this data set has been used to assess circulating biomarker. We all know that in RCC, we don't yet have proper assessment of minimal residual disease. And we believe, if we think about other tumor types, that this is a need to highlight or to identify patients who have an increased risk of recurrence. So what we presented was a retrospective exploratory analysis of circulating protein biomarker to identify high-risk patients with minimal residual disease who may show actually an increased benefit from atezolizumab treatment.
Thank you, Laurence. So can you tell us a little bit more about what is the biomarker that looked at? For us, KIM1 is not that familiar, and how things work out.
Yes, so it was a two-step process. The first part was what we called part one, biomarker identification. And there we performed some kind of screening, basically, where we tested over 3,000 proteins using a proteomic assay to look at the circulating protein that would be differentially expressed between baseline post-nephrectomy versus at the time of disease recurrence. So for this, we identified patients who had disease recurrence, looking at their blood draw, looking at the circulating protein, and looking at those proteins that would not be expressed at the same level at the time of disease recurrence. And so there was one outlier, one protein that clearly was highlighted to be highly expressed at the time of disease recurrence. And this protein is KIM1. It was the most significantly enriched circulating protein at the time of disease recurrence. So what is KIM1? Well, KIM1 stands for kidney injury molecule-1. It is a tumor-associated protein. It's a type 1 membrane glycoprotein that we know in RCC for many years. It has been actually known for over 20 years by our colleague nephrologists, because initially it was considered as a biomarker of kidney injury. And we now know for many years that it is also a right marker of clear cell RCC. And there has been work by a urologist to assess KIM1 as a marker for early detection of RCC. So it's very interesting because it has also previously been assessed in the ASSURE adjuvant study. It was in the era of TKI when we tested sunitinib or sorafenib versus placebo. And in this data set, in ASSURE trial, higher levels of KIM1 in post-nephrectomy pre-treatment plasma samples, so really blood draw, it was associated with worse disease-free survival and overall survival. And the good news is that KIM1 seems to be prognostic, but it is also very easy to be measured either in plasma or serum, and it is stable irrespective of the storage condition. So it's the right candidate to serve as a peripheral blood circulating biomarker. So that was the screening part one. Then we moved on to the assessment of KIM-1 with disease-free survival outcome in our study. And so the first step has to be define which threshold should be used. So the threshold in our data set was 86 picogram per milliliter. It's really in line with ASSURE trial definition, which was in the 70s. So really same level of what we consider high KIM-1 versus low KIM-1. And when we look at those two subgroups, the KIM-1 high patients had actually initially higher pathological disease stage, meaning more T3, T4, and plus tumors. And what are the key findings of our analysis? The first one is that we confirm the prognostic value of KIM-1. KIM-1 high at baseline, irrespective of the treatment arm, was associated with worse disease-free survival. Hazard ratio was 1.75. So it is a prognostic biomarker. The second part is that patients with KIM-1 high baseline had an improved disease-free survival benefit with atezolizumab versus placebo. So it means that this biomarker could be also a predictive biomarker of response to immune checkpoint in the adjuvant space. Hazard ratio was 0.72. So yes, it's a subgroup, but what is very interesting is that the same signal had previously been reported recently within the nivolumab plus ipilimumab Checkmate 914 study. So it is the second time that we see a predictive role for KIM-1. And actually, KIM-1 not only is a biomarker associated with kidney itself, but it is related to the response, to the immune modulation, and especially the T cells activation. So that could help to understand why KIM-1 could be a right surrogate, or at least be used for prediction of response to immune checkpoint here in the adjuvant setting. So there is a rationale behind, given the role of KIM-1 with the regulation of the immune system, and especially a response of T lymphocytes. So that was the second finding, the potential predictive role. And the third finding is that patients were followed up longitudinally, meaning we could assess KIM-1 at cycle 4, day 1, and at time of recurrence. And patients KIM-1 high and received atezolizumab were less likely to have an on-treatment increase in KIM-1. And why is the question of increase important? Because in our data set, for the first time, we demonstrate that on-treatment increase in KIM-1 was associated with worse disease-free survival. So it could be a tool to monitor patient, meaning that if patient has an increase, unfortunately, it is very likely that patient will have disease recurrence. And to conclude, we looked at the KIM-1 level at the time of disease recurrence in the larger number of patients. And patients with recurrent disease had an increase in KIM-1 from median of 80 to a median of 172. Unlike the patient who did not have disease recurrence at time of treatment discontinuation, who were extremely stable with their KIM-1 level being at 64, 68 at time of treatment discontinuation. So it means that in IMmotion010 trial, KIM-1 serum levels showed potential as a circulating protein biomarker for minimal residual disease and monitoring of disease recurrence. Because of these findings, we believe that additional studies are needed to confirm the utility of circulating KIM-1 in adjuvant RCC for three different aspects. The first one is to identify those patients that could have minimal residual disease, KIM-1 high, to predict outcome to response to immune checkpoint inhibitor in the adjuvant space. And thirdly, for the longitudinal monitoring for disease recurrence. And I think this is really extremely interesting, although not yet practice changing, because we need the prospective validation. But this is opening our field to the use of circulating biomarker.
Thank you, Laurence. You made it so easy to understand. I have a couple of questions from the urology perspective, because as you mentioned, we had Kim-1 in the market for several years, and we've known about it, and it has been used as an immunohistochemistry marker, but it never progressed any further in terms of predicting advanced disease. So why do you think now that if we look in blood instead of immunohistochemistry, it actually makes a difference? It's something that comes to my mind, because also like we're looking at all these PDL1, expressions and all these things, and at some point they don't really translate into anything else. So does it make a difference? What do you think? How is this gonna evolve?
Yes, so I think you're raising a very important point. What's the interest of moving from a tissue-based biomarker to a blood-based biomarker? I mean, the urologists are well aware of what's happening in the bladder field and how ctDNA has the potential maybe to help to identify those patients with minimal residual disease, what we call MRD. And I think we were really behind with RCC, and for the first time, we're catching up a bit. It's when you have a patient that had surgery, of course, you can look at the tissue and have tissue-based analysis. But what is important is what's happening in the patient. Do we still have disease in the body somewhere else? And this is what we need to capture. Is there any residual disease? And that's exactly what we want to capture with minimal residual disease assessment. So having something in the blood is more illustrative of what's happening versus what was in the body, but you performed surgery. So the tumor was taken out. And it doesn't mean that the biology is not interesting in the tumor. Of course, it's extremely important. But having some kind of surrogate to assess if there is residual disease is very important to me. It's important because it's opening the field of, can we trigger prompt intervention in those patients that have no detectable disease on the scans, but have something detectable in the blood. And so not only it's useful to say, oh, should I go or no go for early, maybe, for instance, here, decide on adjuvant strategy, although it's not yet demonstrated, but that would be the hypothesis. And the second thing is monitoring our patients. I mean, once again, in RCC, we don't have a blood biomarker, but having something that could allow the follow-up of the patient is so useful, that would prompt maybe earlier CT scans. And I think, it's really exciting to think that we could be able to move toward this strategy.
Okay, so it looks like we found the biomarker for kidney cancer that we did not have until now. And so what I understand from what you're telling us is that you would use this biomarker to intensify or de-intensify your treatment options, correct? Not so far because it hasn't been validated, right?
So I'm not going to use it tomorrow because we need a prospective validation. But the good news is that there are adjuvant trials, some of them being academic, where I hope we can further validate this biomarker. And I hope that at the end of the day, as you say, they will help us to potentially either intensify our adjuvant strategy or potentially de-intensify, meaning not offer adjuvant if not needed, but that needs to be demonstrated. And I hope also that it will help to monitor the patient, because we all know that if we're able to have early intervention, this is sometimes where we can make the larger difference in the long run for a patient.
Okay, I think we got a clear idea, and we're moving forward into the biomarker screening in kidney cancer. Finally, thank you so much, Laurence. We look forward to next podcast and hearing more about biomarkers. Thank you.
Thank you for listening to this episode of EAU Podcast. To keep up to date with kidney cancer developments, visit our educational platform, UROONCO Kidney Cancer. For more EAU podcasts, please go to your podcast app and subscribe to our EAU podcast channel for regular updates.